If you open your mouth right now and just, look in the mirror, you are looking at one of the most complex, unforgiving biological landscapes in the human body.
Yeah, it really is.
And it's a place where a lethal disease can basically hide in plain sight. I mean, it's a strange quirk of human behavior that we can be absolutely meticulous about certain medical routines and completely blind to others.
Right, like we compartmentalize it.
Exactly. Like if I asked you about your last standard medical screening blood work, a mammogram, a prostate check, you likely have that on a calendar.
Mm-hmm.
But here is a startling reality for you to consider.
Mm-hmm.
Oral cancer has an incidence and mortality rate that is nearly double that of cervical cancer.
Wow.
Yeah. Yet while most people are acutely aware of standard gynecologic exams, almost no one remembers their last oral cancer screening.
It is a striking disconnect. I mean, we are talking about 30,000 new cases a year compared to roughly 13,000 for cervical cancer.
That's a huge gap.
It is. And the mortality rate sits right around 50%. So half of the patients diagnosed with this will ultimately die from the disease.
Which is just staggering, and that is exactly why we are taking a deep dive today into a massive, comprehensive medical text. It's simply titled, Chapter 32, Oral Cancer Treatment.
Right.
Our mission today is to uncover why an area of your body so easily accessible to the naked eye is home to what the medical community calls a forgotten disease.
Yeah, it's a very fitting name, unfortunately.
We really want to understand how a disease sitting right there in the mirror can be so deadly, and to explore the fascinating high-stakes medical chess game involved in treating it.
Well, that chess game requires us to look at the intricate intersection of human anatomy, cancer biology, and, the evolution of medical innovation.
Right.
The oral cavity plays a central role in your ability to speak, to chew, to swallow. So treating a cancer there isn't just about removing a tumor.
It's about preserving function.
Exactly. It is about fighting to preserve what makes a person able to interact with the world around them.
Okay, but if the mouth is so easy to look into, I mean, you literally just open it and shine a flashlight, I don't understand why we are missing this until it's a 50% mortality coin toss.
Right.
Why are these tumors going unnoticed?
So the source material highlights a fundamental flaw in our healthcare behavior. Asymptomatic early-stage oral cancers are almost always caught by dentists.
Okay.
But physicians in medical clinics, they usually catch the later symptomatic stages, when it hurts or when it bleeds.
Oh, I see.
The paradox here is that the high-risk population for oral cancer people who might have a history of heavy tobacco or alcohol use, they are 4 to 6 times more likely to see a medical doctor for other health issues than they are to sit in the dentist chair.
Oh, man. So the people who most need the screening are sitting in the wrong waiting room for early detection.
Precisely. They're just not getting those routine dental checks.
But how does this disease actually begin? Because it doesn't just, sprout overnight. What does the very beginning of this look like in the mouth?
It typically follows a pretty orderly progression. The flat, pavement-like cells that line the inside of your mouth, they're called squamous cells, they begin to slowly transform.
Mm-hmm.
Clinicians look for pre-malignant lesions, specifically something called leukoplakia.
Leukoplakia.
Right. These are predominantly white patches on the oral mucosa. Now, not all leukoplakia turns into cancer, but it is a massive red flag.
Like a warning sign.
Exactly. The tissue is morphologically altered. But to really grasp why oral cancer is so insidious, we have to look at a concept introduced back in 1953 by a researcher named Slaughter.
Okay.
He called it field cancerization.
Okay, let's unpack this. It's like a bad patch of grass. You can pull the weed, right, the visible tumor.
Yeah.
But the whole lawn has been exposed to the exact same toxic weed killer over years and years.
That's a great way to think about it.
Yeah.
What's fascinating here is the underlying reality of that condemned mucosa, as they call it.
Condemned mucosa. That sounds ominous.
It is. A surgeon might go in and remove the visible tumor, and the pathologist might look at the physical edges of that removed tissue, the margins, and say the margins are clear, no visible cancer cells here.
Right.
But that visually normal tissue left behind in your mouth isn't truly normal.
Because it's still part of that same toxic lawn. But what does that actually mean chemically? Like, how is it broken?
At a molecular level, that surrounding tissue harbors dangerous mutations. For instance, the text discusses alterations in the p53 gene.
Okay, what does p53 do?
Think of p53 as the cellular spell checker. Its whole job is to catch DNA typos and fix them, or just destroy the cell before it replicates.
Oh, wow. Okay.
When that gene is corrupted, those typos replicate out of control. There's also the EIF4E proto-oncogene, which is another critical blueprint that gets hijacked to fuel tumor growth.
And these are just broken everywhere.
Yeah, these blueprints are already corrupted across the whole mouth. The text cites a really wild study involving mirror image biopsies.
What's a mirror image biopsy?
They took biopsies from the exact opposite side of the mouth from where the cancer was. Completely normal-looking tissue.
Right.
And they found dysplasia, abnormal precancerous cell growth 30% of the time.
Wait, 30% on the opposite side of the mouth.
Yes, exactly.
So the next time you are sitting in a dentist's chair and they pull your tongue to the side and feel around your cheeks, you really need to appreciate the profound importance of what they're doing.
Absolutely.
They aren't just looking for cavities, they are surveying the soil.
And because that soil is so biologically compromised across the board, physically cutting out the immediate threat isn't just a matter of snipping off a skin tag.
Right.
It turns the physical removal of the tumor into an incredibly terrifying anatomical guessing game.
Let's talk about that surgical strike. How do you remove a cancer while ensuring the patient can still function?
It's tough.
The text outlines that the standard surgical approach aims for a 1 to 1.5 centimeter margin of healthy tissue around the tumor. And to check this, surgeons use intraoperative frozen sections. They literally freeze a slice of the tissue while you are still lying on the operating table to see if they got all the cancer cells.
It is a high-pressure moment for the pathologist, let me tell you. But the illusion of the clear margin is a very real limitation.
What do you mean?
Pathological analysis under a microscope in the middle of a surgery just isn't foolproof.
Wait, let me push back on this for a second. If the frozen section during surgery says, we are clear, but the final detailed pathology report comes back a week later and says, actually, the margin is positive for cancer cells.
Right.
Do you just go back in and cut more? Logistically, shouldn't you just reopen the patient and take another centimeter?
It sounds incredibly logical, but in practice, re-excision is fraught with impossibility.
Really? Why?
First, when the surgeon closes that initial wound and reconstructs the defect in the mouth, the remaining tissue is pulled, stretched, and completely reoriented.
Oh, I didn't think about that.
Finding the exact microscopic spot where that positive margin was is like finding a needle in a haystack that's just been run through a blender.
Wow. Okay, so you literally don't know where the edge is anymore.
Exactly. Furthermore, that blender is full of tissue where the measurements themselves have completely changed. Human tissue shrinks 25 to 30% once it is removed from the body.
Wait, really? It shrinks that much?
Yeah. You lose the blood perfusion that inflates the tissue, and the muscle fibers naturally contract without nerve signals. So the centimeter the surgeon measured in the body is now 7 millimeters on a slide.
That is wild.
Ultimately, a positive margin on a final pathology report often reflects the aggressive biology of the tumor itself.
Like what?
Like its ability to use nerves as an escape route, a process called perineural invasion. Because of this, sending the patient for postoperative radiation is usually a much better next step than attempting to blindly cut more tissue.
Here's where it gets really interesting, though. When we talk about surgery in the mouth, we have to talk about the jawbone.
Oh, yes. The mandible.
Imagine you are told you need oral surgery, and the doctor says they have to take your jaw. The source material highlights a wild historical fact about this.
It's pretty shocking.
For decades, surgeons routinely sacrificed the entire mandible in what they called commando operations. They would take the tumor, the floor of the mouth, the neck lymph nodes, and just cut out the entire jawbone, leaving patients permanently disfigured. And they did this because of a mistranslation.
It is one of those moments in medical history that just forces you to pause.
Yeah.
In 1902, two researchers, Polya and von Navertel, published a paper recommending the removal of the periosteum when excising oral cancers.
Okay, the periosteum.
Right, which is simply the thin, fibrous outer layer, the skin of the bone.
Okay.
But a doctor named McGregor mistranslated their work. He thought they meant removing a full segment of the bone itself.
So for decades, patients lost their entire jawbones, losing the ability to eat in public or speak clearly because of a language error.
Yes. The tragic irony is that later research, specifically by a surgeon named Marchetta, proved that the jawbone actually acts as a fortress wall against cancer.
Oh, wow.
The cancer doesn't easily flow through dense bone. It has to actively secrete enzymes to erode into it.
Right.
Today, unless the tumor is actively invading that bone matrix, surgeons use a technique called a marginal mandibulectomy.
which basically just shaving off the top layer of the bone rather than cutting the whole jaw in half.
Exactly.
You preserve the continuity of the jaw, which means the improvement in the patient's quality of life is just immeasurable.
The mechanical engineering of keeping the jaw intact is a triumph. But curing the local site in the mouth is still only half the battle.
Right, because once this cancer develops the genetic mutations to break free from its point of origin, it travels.
Mm-hmm.
Tumors degrade the extracellular matrix holding them in place, and they slip into the highly permeable vessels of the lymphatic system. The neck becomes the cancer's highway system.
The neck is absolutely the primary escape route. The source text is unequivocally clear on this truth. Lymph node status is the single most important prognostic factor in head and neck cancer.
Wow.
The moment that cancer has successfully reached the lymph nodes, the patient's chance of survival instantly decreases by 50%.
50%, just like that.
Just like that.
So naturally, surgeons historically went after the neck with everything they had. The text describes the historic radical neck dissection, and it is absolutely brutal.
It really was.
They would remove lymph node levels 1 through 5, the jugular vein, the sternocleidomastoid, that large muscle you feel on the side of your neck, and the spinal accessory nerve.
Yeah.
Patients were left completely disfigured and physically unable to even lift their shoulder.
The operating philosophy at the time was that you had to clear-cut the entire forest to stop the fire from spreading.
Wow. Yeah.
But as our understanding of how fluid drains through the neck improved, the surgical approach evolved into the selective neck dissection.
Okay, selective.
Surgeons learned they could preserve the muscle, the jugular vein, and the nerve, and only carefully extract the specific nodal basins most at risk, typically levels 1 through 3 for oral cancer.
So you preserve the patient's physical function without compromising the oncological outcome.
Exactly.
There is a quote in the text from Dr. Blake Cady that I think perfectly captures the modern philosophy on this. He said that lymph node metastases are the speedometers of the oncologic vehicle, not governors of survival.
That marks a profound shift in perspective.
How so?
It means the lymph nodes in your neck aren't necessarily the engine driving the death of the patient. They are the dashboard indicator. They show the clinician exactly how fast, aggressive, and systemically capable the cancer is.
Which brings us to a technique to read that speedometer that sounds straight out of science fiction, the sentinel node biopsy.
Right.
If the lymph nodes are the highway, this is how you find the exact off-ramp the cancer took.
Mm-hmm.
The surgeon injects a radioactive colloid and a blue dye right around the primary tumor in the mouth.
It is an elegant concept in theory. The idea is that this radioactive blue tracer will naturally flow down the lymphatic tubes and drain into the very first lymph node the tumor communicates with.
The sentinel node.
Right. The surgeon then uses a handheld gamma probe to listen for the radioactive signal, makes a small incision in the neck, finds the glowing blue node, and pulls it for testing.
Okay.
If that specific node is clear of cancer, you theoretically don't need to surgically dissect the rest of the neck.
But reading this, I kept thinking about the physics of it.
Oh.
If you have a massive primary tumor in the mouth that you just injected with a highly radioactive tracer, and the sentinel lymph node is sitting in the upper neck just 2 inches away,
Yeah.
how do you find the tiny radiation glow of the node when you are completely blinded by the massive radiation glow of the tumor right next to it?
This raises an important question, and you've hit on the exact physiological limitation of the technique in the head and neck. It is called the shine-through effect.
Shine through.
Yeah. The background radiation from the injection site in the mouth is so bright to the gamma probe that it entirely obscures the delicate signal from the node right next door.
Oh, man.
Think of it like trying to spot a single firefly while someone is shining a massive police spotlight directly into your eyes.
That's a great analogy.
This, combined with the incredibly complex and unpredictable web of lymphatic drainage in the throat and jaw, means sentinel node biopsy is much harder to perfect here than it is in, say, breast cancer or melanoma, where the distances are larger.
So if surgery leaves microscopic disease behind in that bad soil, or if the tumor is simply too large to cut out, or if it's already racing down the lymphatic highway, you can't just keep cutting.
No, you can't.
You have to call in the heavy artillery, radiation and chemotherapy.
Radiation biology is a fascinating study in targeted destruction. It relies on the raw physics of cell death.
Okay.
The radiation particles, usually photons, are beamed into the tissue where they interact with water molecules to create highly reactive secondary particles called free radicals.
Okay, so it's a chemical reaction.
Yes. These free radicals act like microscopic shrapnel, literally shattering the DNA strands inside the cancer cells.
Wow.
The cell either dies because its blueprints are too mangled to replicate, which is reproductive cell death,
Right.
or the catastrophic damage triggers a programmed biological suicide routine called apoptosis.
I was poring over this dense section on radiation biology in the text, and there's this concept called the 4 Rs that suddenly made the whole process click for me.
Ah, yes.
Repair, reoxygenation, redistribution, and regeneration. I always wondered why cancer patients go to the hospital every day for 6 weeks for radiation instead of just getting zapped with one massive beam on day one.
Right, it seems counterintuitive.
But reading this, I realized they are playing a microscopic timing game. They are giving the normal tissue just enough time to repair itself between doses while trying to catch the rapidly dividing tumor cells in the specific vulnerable stages of their life cycle where their DNA is exposed.
That timing is everything. And modern techniques like IMRT intensity modulated radiotherapy
That's right.
allow oncologists to sculpt that radiation beam in 3 dimensions.
Okay, so it's more precise.
Much more. They can hit the tumor bed with a massive dose while curving the beam to spare the spinal cord or the salivary glands.
That's incredible.
There is also brachytherapy, where radioactive seeds are planted physically directly into the tum.
Oh, wow.
It delivers an incredible local dose, but carries a severe risk of killing the jawbone entirely, a condition known as osteoradionecrosis because the bone's blood supply is destroyed by the radiation.
But the chemoradiation technique that absolutely blew my mind reading this text is the Radplat protocol.
Oh, Radplat. Yes.
Okay, imagine a medieval city under siege. Radplat is like sneaking in and pumping a lethal poison directly into the enemy garrison's specific water supply inside the castle, while simultaneously handing out the antidote to all the innocent civilians in the surrounding countryside so they don't die from the runoff.
If we push that medieval analogy further, Radplat is basically threading a microscopic hose right into the castle's main aqueduct.
Okay.
Surgeons thread a microcatheter up through the patient's arteries, navigating directly into the specific feeder vessels supplying blood to the oral tumor.
Right into the tumor.
Once there, they deliver a massive, supralethal dose of a chemotherapy drug called cisplatin directly into the cancer.
A dose so high that if it hit the rest of the body, it would normally kill the patient.
Yes, the systemic toxicity would be fatal.
Wow.
But simultaneously, through an IV in the patient's arm, the care team floods the rest of the systemic circulation with a neutralizing agent called sodium thiosulfate.
The antidote.
Exactly. So the tumor gets an unfiltered, devastating blast of chemo, but the exact moment that drug flushes out of the tumor's capillaries and hits the main bloodstream, it bonds with the thiosulfate and is instantly neutralized into a harmless compound.
It yields incredible local control of the tumor, but the text is very clear that this isn't a silver bullet.
No, it's not.
This is extreme medicine. It comes with intense, sometimes fatal toxicity. It's a high-wire act where the math has to be perfect.
And managing that high-wire act requires us to look away from the tumor, away from the margins and the chemical warfare, and look at the battlefield itself,
The human host.
the human element. Because treating oral cancer is uniquely fraught. You aren't treating a disease in a vacuum. You are treating a patient who often brings a host of other severe medical issues to the table.
Absolutely.
The text specifically calls out the danger of alcohol withdrawal.
It is a critical, life-threatening variable. Many patients with oral cancer have a long history of heavy alcohol use.
Right.
When you take them into the operating room for a massive 12-hour jaw reconstruction and then place them in the ICU on a ventilator, their body is suddenly cut off from alcohol.
Oh, man.
Alcohol is a central nervous system depressant. When you abruptly remove it, the brain's chemistry violently overcompensates.
Within days, the patient can go into delirium tremens. Their nervous system rebounds into overdrive, causing hallucinations, severe tremors, and skyrocketing heart rates, which can easily lead to cardiovascular collapse.
Wow.
A perfectly executed miraculous cancer surgery can be entirely undone by the physiological shock of withdrawal.
And there is a grim irony that the source points out, a paradox of success.
Yeah.
Because our local control of the disease, the robotic surgeries, the jaw shaving, the targeted radiation has improved so much, patients are living longer. But because they are surviving the initial mouth tumor, we are now seeing an increase in patients dying from distant metastases, like tumors appearing in the lungs years later.
Or from second primary cancers. Remember the bad lawn analogy,
Right.
the field cancerization we discussed at the start?
Yeah.
That doesn't go away just because you remove the first weed. That cellular soil is permanently altered. These patients have a 4 to 7% chance of developing a brand new, biologically unrelated squamous cell cancer in their mouth or throat every single year for the rest of their lives.
So what does this all mean for the patient sitting in the chair?
If we connect this to the bigger picture, a patient's survival is often dictated more by their overall health, their baseline performance status and lung or heart comorbidities, than by the actual TNM stage of their cancer.
That makes sense.
The host-tumor relationship is durably, permanently altered. As one researcher in the text noted, these patients are rarely truly cured. They are entered into a lifelong, high-stakes management phase.
And that places an immense emotional burden on the surgeons and the care teams. The end of this dense medical chapter really slows down to reflect on this human cost.
It's a heavy burden.
Surgeons have to be prepared to handle massive facial wounds, intractable nerve pain, and the sobering reality that despite their best efforts with a scalpel or a radiation beam, the inability to swallow properly, leading to aspiration pneumonia, is the ultimate cause of death for many of these patients. Palliative care, the medical discipline of focusing strictly on quality of life, dignity, and pain control, is just as crucial a skill for these doctors as operating the surgical robot.
It is a profoundly humbling reality. The biology of the disease commands ultimate respect. You could have the sharpest scalpel and the most precise mathematical radiation model, but you are still fighting against a fundamentally altered biological landscape that wants to keep producing disease.
We have covered incredible ground today. From the corrupted cellular soil of leukoplakia, through the intense mechanical engineering required to preserve a human jawbone, down the permeable lymphatic highways of the neck, and into the targeted lethal chemical warfare of modern oncology.
It is a grueling journey for the patient and a complex, constantly shifting puzzle for the clinician.
But I want to leave you with a final lingering idea to ponder as we wrap up this deep dive. If a patient's survival depends so heavily on the biological aggressiveness of the tumor and the condemned nature of their entire mouth, if the soil is forever changed and the blueprints are corrupted, perhaps the true cure for oral cancer in the future won't be a sharper scalpel or a more toxic chemotherapy drug. What if the future lies in utilizing targeted gene therapy to literally rewrite the p53 mutations, reprogramming the genetic soil of the mouth back to health before a single tumor ever has the chance to sprout?
That is the ultimate scientific horizon. Reversing the field cancerization entirely, turning bad soil good again.
Thank you for joining us on this deep dive. Keep questioning the world around you, keep learning, and please, next time you go to the dentist, appreciate what they're looking for and don't ever skip that exam.